So good morning, everyone. I was very fortunate to spend the first half of my year this year working at the ECI. I think it's one of the best rotations I ever had, and I learned a lot about emergency medicine despite it being a non-clinical environment. We, during our time at the ECI, undertake a few different projects, and this was one of the research projects that I did that very fortunately most of the work had already been done by Michael and his team as part of the Destiny project, where we basically were looking at centenarians in New South Wales emergency departments. Now, I know that lots of people think emergency medicine is very glamorous, and most of what we see is things like gunshot wounds, but I think the reality is quite different, unless you work at a place like Liverpool. And the reality is, in Australia, it's an ageing population, and our emergency departments are seeing more and more older patients, more complex patients, and something which I learned during this study is that the age group aged over 100 is the fastest growing age group in Australia. So at the moment there's about 5,000 people in Australia who are aged 100 and over, nearly 2,000 in New South Wales, but they're doubling every 10 years. So you might think the numbers are small now, but over the next 50 to 100 years, they're growing. And in Japan, which has one of the longest life expectancies in the world, the numbers have actually grown quite a lot. So I think it's, quite common in a lot of societies that when people turn 100, they get a commemorative telegram from the Queen. In Japan, you get a silver sake cup, and it's now sending the government broke, because 30,000 people turned 100 last year, and so that cost them nearly $2 million. So New South Wales, this was a report that came out last year. In the next 40 years, the number is expected to increase by 10. So we're looking at 10 to 20,000 100-year-olds coming to our EDs. And our life expectancy, surprisingly, is going to be in the order of the late 80s to early 90s. And looking at the data that we already had, people aged 100 and over are actually the highest presenting group 2 EDs if you look at their population. So the BHI gives their crew presentation rate at about 878 per 1,000 population. What we calculated in our study was closer to around 70%. But I think, we all agree that they're going to be heavy users of emergency departments, and no Australian studies had been conducted looking at this age group. Overseas, there'd been a few studies. So in America, there was a study done around 10 years ago, which was nationwide. They looked at why people were coming to hospital, and the main reasons were falls, pneumonia, and UTIs. And around 60% of them who came were admitted. In England, they found a similar thing, though it was a very small population that they were looking at just in a rural area in England, where they took all their centenarians and just looked at what happened to them over a period of a few years. So this is where this study basically came from, which I'm very grateful to the support I've had from Hattem and Michael and Sally during her time at ECI. So we were able to lift out the presentations for people aged 100 and over from the Destiny study that Michael's already talked about. And we've basically looked at, what happens to these people when they come to ED, and also who are they, because we don't know a lot about this age group. So I was surprised to find that most of them still live at home out of those that are coming to ED. So 77% of patients coming to ED still lived at home, and almost 80% were female, which I think is probably less surprising. In terms of triage categories, most of them were triage 3 or 4, but there is quite an increase in the triage 2s, and perhaps that's related to the sepsis pathway that's been introduced during this time, or are they presenting more unwell than what they did before? But I think we can see that there is already an increase in demand looking at these numbers, and over the coming decades, we're going to see a lot more of these presentations. So why do they come? So what we found was similar to the American data, that 30% were related to falls. And if you looked at the actual admitting diagnosis, 7.5% of them were given a diagnosis of fracture, whether it was a fractured noff, a fractured wrist. 11% still just were given an admission diagnosis of falls. We don't know whether those included fractures or not. And then the next most common category were respiratory complaints, so predominantly pneumonia. Around 10% had cardiovascular problems and almost 10% had abdominal problems. So these were basically using the categories that Michael and his group had already gone through. So 64% needed admission. So I think looking at the presentation we've just had, if you've got someone coming to ED who's aged 100 or over, they're more than likely going to need to come in, so you should start looking for a bed. And the representation rate was fairly similar to the general population. What was their length of stay in ED? So this is the mean length of stay looking at the different categories for which they presented, and you can see that all of them were in ED for more than 4 hours, well and truly. On average, it was around 6 hours that they spent in ED. And so you can imagine that this is a huge workload for the emergency department, and if we can streamline the process to get them through, then we can help to unclog our beds. And we also looked at month of presentation, so there was a slight peak during winter, which I think isn't unexpected. So how can this help us in our work in the emergency department? So I think given their high admission rates and the fact that they are spending large amounts of time in the ED, we need to look at processes for streamlining them through. Or is there a role for geriatric assessment units for these sorts of patients that would expedite their care as well as their journeys through the healthcare system? In America, there's a growing trend towards senior emergency departments. So in Australia, we're seeing a lot more paediatric EDs being opened. Is there a role for separate geriatric EDs? I think we have a lot of recognition that children are different from adults, and there's a lot of emphasis on paediatrics during our training. In the same way, geriatrics are different from other adults, and I think that's been well recognised in America and is probably becoming more so in Australia. So the geriatricians have proposed that existing models of ED care don't really apply to older patients, and perhaps we should be looking at how things are done in Australia. I think we also need to redefine old age. So looking at all the research projects that I read as a part of this project, old age is defined at 65 years and over. And I think there's probably a few people here who would disagree with that. With our increase in life expectancy, and as a research tool, we should probably be redefining it. A 100-year-old is very different from a 65-year-old. Not all old people are the same. So this is from WHO, which has just recently released a focus on ageing and health around the world, because this isn't unique to Australia. It's common to even developing countries that their populations are now starting to age, with people surviving through communicable diseases. And an ageing population means, more and more chronic disease. But something which was new to me is that not all old people are the same. So people with chronic disease tend to die in their 80s or 90s. If you made it to 100, you generally have got through all of those things. And many people who are aged 100 don't actually have any chronic disease at all. Now, that doesn't mean that we should be performing heroics. They should be going to ICU. We need to be developing pathways that are appropriate for them, because many of these people are still very frail. But I think we need to get away from the idea of just thinking about all old people in the same category and trying to learn a bit more about different ways that they present and what things would be appropriate for them. And just picking up the most common reason why they've come to ED, which is injuries, so falls. There's a lot of work that can still be done around injury prevention in order to reduce or to prevent these people having to come to the ED to begin with. So there are already a lot of programs targeting falls preventions around. And just this week, JAMA has released a new study showing that not just exercise, which can reduce falls by about 50%, but other things such as vision assessments, vitamin D supplements, and things like home repairs can make a big difference. So I just wanted to acknowledge again Michael and the Destiny team and the funding from ECI, and hopefully we'll be seeing more and more of these people in our emergency departments.